Okay then, so welcome to today's session then. My name is Atif Sadiq and this is the Pharmacy Foundations online revision course drop-in session for the CNS Central Nervous System webinar / recorded video that you guys may have accessed already. Through the course then so far we have covered the likes of over-the-counter medicine, genitourinary cardiology, endocrine, etc. But like I say, today's focus is mainly going to be the central nervous system chapter of the BNF. So that's what we are going to be focusing on. As a bit of a background, I think you guys are aware of Pharmacy Foundations already, but there are a few different things that we do offer. So for those of you who are currently in your foundation training, do make sure that you make access or make use of all of this. In addition to that, there are certain things that we are doing for undergraduate and postgraduate students. And as you can see here, a wide range of offerings through the Pharmacy Foundation projects. So Pharmacy Foundations, if you weren't aware, we're an independent training organization, and we have a number of pharmacists working across a variety of different settings. Therefore, all the information and all of the content that you see with the Pharmacy Foundations offering is usually rigorously checked and double-checked by our colleagues. Like I mentioned before, my name is Atif Sadiq, so I am the head of education here at Pharmacy Foundations, and some of you may have come across me through my roles at the University of Bradford as an assistant professor, or through my roles at Health Education England, or even actually as my role with GP practice as an advanced clinical practitioner. So I do prescribe, I do work as an advanced practitioner, and hopefully with today's drop-in session, I'll be able to draw on some of them experiences for you all. So if you haven't done so already, then Pharmacy Foundations, do make sure you follow us on social media. There's quite a lot of different things that we do offer, things like quiz questions, exam questions, scenarios, revision posters, etc. So if you're not on our social media platforms, do make sure you give us a like and a follow. And we are on WhatsApp as well. So you might have seen, because the exam's coming up, there are certain questions that we are putting on there. So it'd be worthwhile for you to join us on that platform as well. Righto. So let's go ahead and then dive into the focus for today's session. So today's session is to supplement the central nervous system online video that we posted last month, so in March. And I'm presuming some of you will have already had a go at watching this. Some of you are still to watch this. So in order to tailor the session a little bit better, I just have an initial poll that I would like for you guys to participate in. So I'm just going to release this on your screens. Just so I know how to tailor the session, can you just go ahead and select your response, whether or not you've had the chance to watch the nervous system video as of yet? So remember, today's session, it is more of a drop-in, so an opportunity for you to ask any questions associated with the video. If you can go ahead and vote on that poll. I don't know if you guys can see that. I'm hoping you can, but I've got it active on your screens, hopefully now. If you want to just give me a response, that would be great. Okay. I'm not getting any responses coming through, so I don't know if it is working. In the chat, if you can, just let me know. Is that working? And if it is, can you just kindly vote for me? If it's not working, then we can quite easily end that there as well. Let's have a look. Perfect, it is working. That is fine then. So I'll just end the poll there then, and let's see what the results are like. Appears that we've not had, I can't see any results on my side. And I think that might be, I think Imran's in the background, so I might not be able to see certain results. But if you want to just post into the chat for me, Imran, and let me know what the outcome is, because yes, perfect. Okay, so 4 out of 15 have said yes, and 11 out of 15 have said not yet. Okay, that is fine. So I'll obviously I'll tailor the session accordingly then. So obviously I'll make sure that anything that we do cover, we cover in a way that allows us to address any of the questions that you may or may not have. So layout for today's session, then how are we going to get through this drop-in session? What kind of things are we going to focus on? So to begin with then, we will have a look at the CNS and the registration assessment framework. Now this is something that's already covered by the nervous system session. So rather than what we are going to be doing today, this particular slide is what does the nervous system session cover. The next slide is going to be about what we are going to be doing as part of today's session. So nervous system video, if you haven't watched it, then do make sure you go ahead and have a look at this. The kind of things that it does cover then includes your CNS and how it links in with the registration assessment framework. Quite usefully, we've also broken down the actual session into key areas of focus based on the subsections of the BNF. So what you'll find is when it comes to the nervous system, for those of you who haven't started the topic yet, it's broken down into key subtopics. So things like dementia, mental health, pain, movement disorders, substance dependence, and epilepsy. So what this video does is goes through these in key detail. So hopefully when you do watch that, you'll see that. Strategies for breakdown of the chapter. So a lot of you will have already started your revision, and you will have noticed, or if you haven't started your revision, you will have noticed that this particular chapter is massive. So there's quite a lot for us to cover as part of the CNS topic. And a lot of the times, trainees do struggle with the sheer volume of the content for the nervous system chapter of the BNF. So hopefully when you do have a look at the video, you'll see that there are certain strategies that you can implement in order to make your job a little bit easier when it comes to the nervous system chapter. And the last key thing that you'll see that the nervous system session, which again, like I say, is available as that video, focuses on the core knowledge to allow application to the exam. Because one of the things that I found over the years, particularly with trainees and the registration assessment, is that generally speaking, most trainees will be doing quite well with most of the questions. And when people tend to pass or when they tend to fail, it tends to be the difference of 1 mark or of 1 question. So this last point is vital, because often when you do struggle in an exam, you do need to rely on your core or your foundational knowledge. So what we do through this session is we focus on the core knowledge that is going to allow you to answer some of the more challenging questions. And through the video then, obviously, in the package itself, you'll see that there are some useful revision posters and case studies. So if you haven't yet had the chance to watch the video, do make sure you go ahead and do that. But let's move on to the layout for today's session then. So what are we going to do today? So today, hopefully, we're going to start off with answering the questions you guys have sent through via email. In addition to this, we'll be looking at the popular section. This is based on the analytics that we have for those of you who have watched the videos, is areas that you tend to pause the video on for quite a while. So hopefully what we'll be able to do is revisit that. Sometimes it's because you're really enjoying that section. Sometimes it might be because, you know, there's a lot of notes that you are wanting to take down. So I'll be revisiting a particular section of the session today. There is a bonus CNS question, just the one. This is something that I thought I'd throw in as a little bit of a treat for those of you who have joined today. And then towards the end, then I'll give you guys the opportunity to ask any questions in the chat as well. So hopefully we'll be able to answer any questions that you have in the chat. So that's the plan for today, hopefully. I'm hoping you guys are ready, raring to go. If you are, just give me a smiley face or a thumbs up in the chat. Hopefully now I'm not going to have any problems with the IT. So that's a thing of the past, but just give me a thumbs up or a smiley face or something along those lines in the chat. And Imran, if you are on the session, I think it might be worthwhile for you to leave and rejoin, because you're taking away everything that I can and can't see. So if that's okay, that would be good, because otherwise they will not be able to see anything in the chat, it seems. Perfect. Okay, that's fine. So I've got a couple of smiley faces coming through. That is great, and that is fine. So let's start off with then the emailed questions, because like I say, it's a drop-in session. So I want to make sure everyone's feeling confident with regards to the topic, whether they've watched or haven't watched the video. So here we are then. So the first question that you guys asked, or one of the key questions that you guys asked in relation to the CNS chapter and the registration assessment was, how much do we need to know about pediatric CNS conditions? So a very valid question and a very important question, because, you know, the exam's not too far off now. If you're looking at June, pretty much around the corner, really. And you only have a limited amount of time to prepare and a limited amount of time to revise. So, like I say, it's a very useful question that one of the colleagues or one of you guys have sent through. And I will try and answer this question, you know, as thoroughly as possible now. So the key thing here, I would say, is what I have mentioned in the previous videos that you might have seen, is that when it comes to the registration assessment, when it comes to the pre-reg exam, we're not necessarily asking you, or the GPHC is not necessarily asking for you to be a specialist in any particular clinical area. Yeah, so we're not expecting you to be a psychiatrist or a pain specialist or anything like that. It's more so that we expect you to be able to practice safely as a day one pharmacist. So that's a recurring theme that you'll hear me say time and time again. And the reason why that's important is particularly in relation to this question here, because when it comes to pediatric CNS conditions, understandably, some of them are really specialized. And some of them, you know, we tend to see day in, day out when we've, for example, got a prescription in community pharmacy, or we're on a general ward in a hospital, or we're working in general practice. So the kind of things that I would say that you need to know in detail when it comes to pediatric knowledge and the exam and the CNS chapter itself would be things like, obviously, your ADHD. So you see that quite a lot. It's not that, you know, we need to be specialists to be able to diagnose. Well, we do need to be specialists to be able to diagnose ADHD, but it's not that we don't see that medicine day in, day out. So knowing what kind of medicines to give for ADHD is key. I would say you need to know that for adults and for the pediatric patients. But in addition to that, there's things like that we see quite often, things like depression. You know, we need to know how to manage depression in pediatric patients. So with that in mind, I'm going to list a few other things as well. But before I do, let's see what your guys' thoughts are then. So for those of you who have watched the video, you should be able to answer this a lot easier than others. But things like, for example, depression. What is the first line antidepressant for depression then? If you want to just throw that into the chat for me, let's keep you on your toes. Because as well as absorbing some of the knowledge that I've got to offer today, it'd be worthwhile to hear from yourselves. First line antidepressant in specific, though, I know it's SSRIs. That's baby knowledge. That's easy knowledge. I'm not asking that. I'm asking for something in particular. Which SSRI is recommended in pediatric or younger patients? Go ahead and type away in the chat. So a lot of you saying SSRIs, and then sertraline is a popular one. But now I'm getting the correct answer through. Yes, fluoxetine. So fluoxetine is the antidepressant of choice in the patients below the age of 18. So these are the kind of things that you want to focus on when you are looking at your knowledge. Other things to bear in mind then, things like pain. You have seen in our OTC session, and you will have also seen in this particular CNS video, is when it comes to pain and the management of pain, we need to know what to do for pediatric patients. And a lot of the times you will see either ourselves or other organizations highlighting the importance of being aware of the dose of paracetamol, ibuprofen for pediatric patients. If you do not know the pediatric doses for paracetamol or ibuprofen off the top of your head, you definitely need to go back to the drawing board and learn them, because it is a very popular exam question. Beyond this, then, what are the things that we need to be aware of when it comes to pediatrics? I would say epilepsy. That's another key one that we need to be aware of. And then there are certain drugs where there are MHRA alerts associated with their use in pediatric patients. So, for example, one of the MHRA alerts is to do with domperidone and pediatric patients. And I'll summarize this in a few moments. So if you are making notes, hopefully we can refer back to that. And obviously this is also being recorded. But yeah, domperidone, there's an MHRA alert associated with domperidone in children. Does anybody know what that might be before I go ahead and reveal what I was going to say there. Domperidone and children or child patients, there is often an MHRA alert associated with that. And because there's not much of an activity in the chat, I feel like you may or may not have come across this before. But the key thing with this domperidone is that anybody below the age of 12, there's no real evidence that it works. So it should be avoided in patients below the age of 12. So you'll see an MHRA alert for that. And another one, actually, if you're looking at another anti-sickness medicine, we're thinking about metoclopramide. Now, with metoclopramide, the key thing there is that metoclopramide can cause dystonic reactions. So I talk a little bit about movement disorders in that video, so do make sure you look at that. But when it comes to metoclopramide, in young patients, particularly in young female patients, it can cause dystonic reactions. So it can cause dystonia of the muscles. So in relation to that first question then, if I was going to summarize, how much do we need to know about pediatric conditions or CNS conditions? Well, the answer to that is obviously pain. We need to know about that in detail for pediatrics, depression, ADHD, epilepsy, and any MHRA alerts that you come across. Other stuff like bipolar disease and, you've got things like dementia, they're not going to be managed by a normal clinician. It's not going to be something that does not require the input of a specialist. So that kind of stuff, purely focus on it from an adult point of view, but do open up your children BNF for things like I say, pain, ADHD, epilepsy, depression, MHRA alerts, etc., etc. So hopefully that helps answer part of that question there. Second question then is from someone in relation to services. So this is another very good question to ask, because at this moment in time, it's not that it's lazy that you're missing out certain parts of your parts of revision or certain parts of knowledge, I would say. It's not that it's lazy. I think it's quite smart, because you've only got a limited amount of time from now until the exam. So you want to make sure you're focusing on the right things. And again, I really like this questions, or this question in particular, is because it allows you guys to block out some of the stuff that you need to know for practice, but you don't necessarily need to know for the exam. So it says over here, do we need to know the specifics about substance misuse services? Now, the answer to this question is, I would say technically no. And the reason for that is because what you've got to remember, the exam, the GPHC exam, is an exam that will be sat by candidates in Scotland, England, Wales, and Northern Ireland. And the service requirements for these different devolved nations is very different. And the GPHC it would be unfair for the GPHC to ask you something specific about a service in England that does not apply to a service in Wales or a service in Scotland or a service in Northern Ireland. So these kind of specifics, how much do you get paid, how much is the prescription cost, etc. These specifics will be not tested in the exam, because obviously they do not link in with all of the countries. We need to think about things that link in with all of the countries. And that's why I would say when it comes to the specifics of substance misuse services, you don't. Now, don't get the specifics of substance misuse services confused with the clinical side of things when it comes to providing these services. So that's a very key point. I say don't get confused with the service requirements and what you need to know clinically. Yeah, because, for example, one of the service requirements for the methadone service here in England is that if patients miss more than 3 days of their methadone, then you need to refer them back to the prescriber. But that has clinical implications. There's a reason why we say that. It's not purely because of the service, it has clinical implications. So again, for those of you who have been concentrating or have seen a video or are otherwise aware, why would we refer patients back to the prescriber if they have missed 3 days of their opioid, like methadone, or maybe even your buprenorphine? What is the reason behind that? Because yes, it's a terms of service in England, but is that the only reason? Is there a clinical implication? Yes, fantastic. Yeah, so as you mentioned in the chat, loss of tolerance. So if you stop taking methadone for 3 days, you build up so your tolerance is lost, in fact. So what you were taking before, let's just say you were taking 20 mils or 30 mils, then as some of you mentioned, them 20 mils or 30 mils that you were taking regularly now become a very high toxic dose, and therefore increases your risk of an overdose. So see, there's a difference between terms of service and a difference between the clinical implications. So the key thing with question number 2 is do make sure that you cover the clinical side of things to services. When it comes to the actual, you get paid after 14 days and you need to send off the prescription and this is how much it costs. That kind of stuff is country specific. So don't focus on the country specific stuff. So that was question number 2. And then the last question was to do with the palliative care section of the BNF, because this is something that I refer to when I'm going through the nervous system with you all in that video, the palliative care section of the BNF. Now, if you weren't aware, and if you haven't seen that video, then I guess newsflash for you, there is a section at the beginning of the BNF known as prescribing in palliative care. Now, prescribing in palliative care is a very important section of the BNF, and a lot of the times students tend to overlook this because, what do you tend to do when you're revising? Let's start off in chapter 1, and then let's move to chapter 2, 3, 4, etc. But this particular section, the reason why it's important is because it amalgamates a lot of the knowledge that you might need to know when providing your service of care to patients who are palliative. And the kind of things that you'll see when it comes to the prescribing in palliative care section is that they are broken down into, I guess, therapeutic areas. So there's things like pain, things like nausea and vomiting. There's a little bit about conversion of opioids. So the short answer to question number 3, what part of the prescribing in palliative care section is relevant to the exam? The short answer to that is all of it. Yeah, all of it to an extent is relevant to the exam. There are certain sections that are more relevant than others. So if you're thinking about pain, that is a very important section because it talks about things like breakthrough pain, about things like, how to convert between one opioid and another. There's also sections there about nausea and vomiting, which is quite important as well when it comes to palliative care. So there are some sections that are more important than others, but I would say you need to read that section, whether you've got the paper copy of the BNF from cover to cover of that palliative care prescribing, or if it's the online BNF, read the whole section. Obviously, there's certain things that you will get access to resources if you're using it in the exam. For example, there's an information about the syringe drivers or the actual doses of opioids. So, for example, X milligrams of morphine equals X milligrams of fentanyl. That kind of stuff you don't need to memorize, but nevertheless, there's lots of gems of knowledge within there. So I would definitely advise for you to have a look. And with that then, let's see what you think about one of the potential, I wouldn't say it's laid out in an exam question format, but one of the potential questions that they could ask you is a bit like what I've got for you as a bonus question, because you guys have joined today. It's something like this, and let's see what you would think about a question of this nature. I've literally gone into the prescribing in palliative care section of the BNF, and I've pulled out this bit of knowledge as a question for you. So have a look at that and tell me what you think, because this is the kind of knowledge that's covered within this subsection of the BNF, the prescribing in palliative care. And I do think it's my Zoom that's having issues because I can't still see any responses there, but I'll rely on Imran or somebody in a few moments to see if they can tell me what the responses are. But I'll give you about another 20 seconds to answer that in case people haven't had the opportunity. And then I'll just end the poll in a few seconds. Okay, that is fine. And so I'll end the poll there then. And I'll share the results, although I can't see the results. I'll stop sharing them for now. Let's see what kind of responses we have got. Do you guys, can you see who's got what? Because I can't see who's answered what. I don't know what the highest response is. It seems like my Zoom is playing up today, unfortunately. What is the response rate like? Or shall I just give the answer? It might just be worthwhile that I just dive into the answer, in fact. Tramadol, 64%. Okay, that is fine, and that is fine. So I'll stop sharing the answers to the poll. And yeah, so 64% of you going with tramadol. Well done. That's the correct answer. Which of the following analgesics is not usually given for breakthrough cancer pain? So what you'll see in this subsection of the BNF, it says things like morphine can be given for breakthrough pain. Oxycodone is another one that can be given, but it's not licensed actually. And then fentanyl can be given as well. And it's all about the immediate immediate acting opioids. So they need to be ones that work quickly. You wouldn't be giving the modified release preparations. And that kind of stuff is listed within this section of the BNF. So hopefully that gives you an idea of how important it is for you to be aware of the prescribing and palliative care section of the BNF for the exam. And hopefully I've answered the other questions there for you as well. So I'm going to take a brief pause now to see if there were any questions about the questions on the slide there. So I'll just briefly pause if there are any questions about the questions on the slide there. Don't be shy to ask. Do remember, you've taken your time out this weekend to join the session, so do make sure you go ahead and ask any relevant questions that you might have. Okay. That is fine. Still silence, so I'm presuming you are quite happy with that. That is fine then. So let's move on then to the next part of the drop-in session before we round off with some Q&A from you all. And the next part of the session is a popular section of the session from the video, Revisited. And like I say, this is based on the analytics that we get through from those of you who have accessed the video. Do we have to, I've got a direct message come through actually. Do we have to know all the specific types of epilepsy? The answer to that question is that we've created 2 separate infographics for epilepsy. So you need to know about the specific types of epilepsy. Yes, the answer to that is yes. Relevant treatment, the answer to that is also yes. So if you have a look at that infographic, there's a 2-part infographic that we've done for epilepsy. And if you have a look at that, that should kind of cover what you need to know. Things like branded anti-epileptics, things like what you need to consider for sodium valproate and pregnancy, etc. But yeah, that's a fairly self-explanatory infographic, and that's the answer, hopefully, to that question that I have got that's come through to me. Okay, so popular section Revisited, and this in fact was the summary of the Parkinson's disease treatment and management and diagnosis. There's quite a few different things that we cover as part of the session. And I do see that a lot of you who have accessed the session already did pause the video here. So I think maybe you were trying to frantically make notes. Maybe you just found the aesthetic quite good. I'm not too sure. But nevertheless, let's go through this briefly again, just to see if there are any questions about Parkinson's disease. So Parkinson's disease then, and this was more of a summary slide. So this came after the case study that you guys will have seen. So Parkinson's disease as a condition, as you guys are aware, is usually due to a lack of a neurotransmitter. So what neurotransmitter is it in question in Parkinson's disease? If we can, in the chat, what neurotransmitter is there lacking? So we have dopamine, we have acetylcholine, we've got dopamine again. Yes, correct. So it is dopamine rather than acetylcholine. So remember, when I cover the dementia, that's more to do with acetylcholine. But when it comes to Parkinson's disease, there is a lack of dopamine in the substantia nigra region of the brain. Yeah, in the substantia nigra region of the brain. And not to worry, for those of you who got confused between dementia and Parkinson's, it's fine for you to get confused here, so long as you don't get confused in the exam. That's the main thing. So obviously, as you guys will be aware, when it comes to Parkinson's disease, It is characterized by the presence of motor and non-motor symptoms. So again, see how well you guys understood what we did cover as part of that video. What are motor symptoms when it comes to Parkinson's disease? What do we mean by motor symptoms? Any ideas? What do we mean by motor symptoms when it comes to Parkinson's disease? So we've got some examples of motor symptoms in the chat, which is good. So dyskinesia, shuffling gait, tremor. But what do we generally mean by motor symptoms? So you guys are giving me some really good examples of motor symptoms, but motor symptoms are those that affect, fantastic, movement. So these are symptoms that are affecting movement. And obviously the non-motor symptoms are all symptoms that are otherwise there present. So for example, symptoms associated with dementia or depression or bladder dysfunction. So all of the non-movement related symptoms are known as non-motor symptoms. Okay, fantastic. And obviously one of the key things that I was trying to highlight in the session was that because dopamine is vital for the movement or the contraction, in fact, of muscles, it's not only vital for the contraction and the relaxation of skeletal muscles, because a lot of us think about Parkinson's disease and the shuffling gait and the movement side of things. It also affects your smooth muscles, hence why it can cause problems with the bladder and other problems that you will have seen. So in addition to this, then, we also mentioned that when it comes to the non-motor symptoms, we need to manage these in specific ways. And one of the non-motor symptoms was, in fact, nausea and vomiting. So what did we say about Parkinson's disease and nausea and vomiting? Which medication is preferred for nausea and vomiting, and which ones should we try to avoid? So this was another thing that we covered, whether you know it already or not. We did focus on that in the session. So which one should we give? Which medicines should we try to avoid, if you can, in the chat? So a lot of you are saying domperidone. I'm presuming you're saying that we give domperidone and we avoid the likes of metoclopramide. Fantastic. And the reason for that is because what you've got to remember, a lot of the antiemetics, so a lot of the medicines that you use that prevent sickness usually focus on working in a way where it's an anti-dopamine mechanism of action, because dopamine, too much of it, can cause sickness. So a lot of the antiemetics work as anti-dopaminergics. And if we are giving anti-dopaminergics whilst trying to preserve dopamine, it might counteract the effects of levodopa or the other medicines that we are using. So the key thing is we're trying to give an anti-emetic that doesn't cross the blood-brain barrier. So for example, the domperidone is a very useful anti-emetic in Parkinson's disease because its anti-dopamine effects are restricted to peripheral circulation. So they don't cross the blood-brain barrier. And remember, the first point that we were making is that Parkinson's disease is caused by a lack of dopamine, not just anywhere, but a lack of dopamine in the brain, in the substantia nigra. So for that reason, the domperidone is really useful because although it might work as an anti-dopamine in the peripheral side, i.e. where it's causing the nausea and vomiting, in the actual brain, it doesn't cross the blood-brain barrier. So if you were to get that question in the exam, hopefully you'll be able to answer that. We also mentioned that obviously when it comes to the treatment of Parkinson's disease, there are a variety of drugs available. And how do we go about choosing which one to use first? How do we go about to choosing which one to use second, etc.? Well, the key thing that we said with this then, it all comes down to the potential impact that the symptoms are having on quality of life. So obviously, you know, you've got things like your levodopa, and that's combined with the enzyme, the breakdown, the decarboxylase enzyme inhibitors. So things like your benzebazide, things like your co-caroldopa, your co-benyldopa. So that's the kind of combinations that we're thinking about. You can give them, but if the patient is suffering from motor symptoms that are not necessarily affecting the quality of life, it's always best to leave levodopa until later on. Because when it comes to levodopa, there are a couple of things. Number one is pretty much the last resort when it comes to the management of Parkinson's disease. So by using it too soon, you're going to exhaust all avenues. And in addition to that, obviously, when it comes to some of the other symptoms, generally speaking, with the levodopa, it's best to leave it until later on. Because like I say, the other treatments, you might as well exhaust them avenues before we start using this very useful medicine. So the key thing here that I was trying to address, in fact, is that when it comes to Parkinson's disease and it comes to the management of motor symptoms, then is all based on whether they affect the quality of life of patients. And if they do, then go ahead and use the levodopa. If they don't, then we would use the other medication that are available. And then the other things that we did focus on as well was side effects. So do remember that all dopaminergic drugs can cause impulse control disorders. So this is something that you'll see time and time again. So the kind of things that we affiliate with impulse control disorders include things like gambling, binge drinking, hypersexuality. So obviously we need to be aware of that. And if any patients are showing excessiveness when it comes to impulse control disorders, then often as clinicians, our job is to review the dose of the dopamine, because it might be that we're giving way too much dopamine. So these are the kind of things to consider. Now, I raised the point about decarboxylase inhibitors earlier as well, and there's a reason why we use these. So decarboxylase inhibitors, so for example, benserazide is a decarboxylase inhibitor, and that is used alongside levodopa in a preparation called corbenyl-dopa. Corbenyl-dopa. So you might have come across that before. Corbenyl-dopa contains a decarboxylase enzyme inhibitor known as benserazide. So can anybody tell me why we use the decarboxylase inhibitors? What is the reason behind us wanting to use them? Because there's a few things that we've covered about Parkinson's disease. I know it's a bit of a whistle stop, but I'm trying to explain some of the intricacies in case you guys were confused, but hopefully we've been able to address some of them now. But tell me, why do we use our decarboxylase enzyme inhibitors when it comes to combining them with levodopa? So let's see some suggestions in the chat then. So we've got a suggestion that says stops levodopa from being broken down before it reaches the brain. Fantastic. You've hit the nail on the head there. So that's another key point to be aware of, is that we combine levodopa with decarboxylase inhibitors, usually given with levodopa, to prevent the peripheral breakdown of the dopamine. Again, remember, the first point is the most important point of Parkinson's disease, which is that it's caused by a lack of dopamine in the brain. So we need to try and optimize our efforts to get the dopamine into the brain. Last couple of points then were about medication, how to use the medicines, and what kind of medicines to use if patients have other non-motor symptoms. Understandably, with Parkinson's disease, because we're giving dopamine, and because dopamine is associated with psychosis to an extent, then a lot of patients who suffer from Parkinson's disease will also suffer from psychosis or psychiatric type problems. So for that reason, we may need to give antipsychotics to patients who suffer from Parkinson's disease. Now, one of the key things that you guys may have realized when you were looking in the BNF is that antipsychotics, a lot of the times, work through an anti-dopaminergic pathway. So they work by reducing your dopamine levels. And for that reason, you might be thinking, well, that's going to counteract the treatment of Parkinson's disease. And if you are thinking that, then you're right to think that, because we want to give medicines that are not going to necessarily counteract that effect. So the antipsychotics that we give in Parkinson's disease, we've got to be very careful with them. Yeah, we can't just give any antipsychotic. So my question to you guys is then, if somebody had Parkinson's disease and they needed an antipsychotic, which antipsychotic would you give them? Are there any particular ones that are preferred compared to others? And this is something that we cover in detail in that session. But let's see how many of you guys who have watched the video were concentrating, and otherwise, let's see how many of you are aware. So what do we think? What kind of antipsychotics would we give? Fantastic. Yes, second generation antipsychotics. So we would give second generation antipsychotics. I wouldn't say olanzapine is the second generation one. I would say it's things like clozapine and quetiapine. These are examples. And you might be thinking, well, why do we give second generation antipsychotics? Well, as I did mention in that session, then the key thing there is because the second generation antipsychotics tend to work on a range of receptors. So they don't only work on dopamine, they work on muscarinic receptors. So the key thing with them is that, you know, they're not going to necessarily cause that much of an impact on the dopamine levels. Last point then, that I'm going to just focus on briefly as well, was the fact that it is very important that we give anti-Parkinson's medicines on time. And the reason for this is twofold. Number one, if we don't give it on time, then you'll realize, for example, if you were to give it every 4 hours, the first dose is at 8 a.m., the next one is at 12 o'clock. You don't give it on time, patients' symptoms might return. So that's obviously not a good thing. We don't want that because it takes a while for us to stabilize patients. But what was the other key reason that we should not be delaying anti-Parkinson's medicines? Can anybody either remember, or is anybody otherwise aware? So number one, obviously, is symptoms will return. You know, we don't want them symptoms to return, particularly if we've been taking a very long time to try and build up a therapeutic effect for the patient. But there's another reason as well. Can anybody remember what that other reason might be, or why making your brains work too hard on a Sunday afternoon, it seems? Okay, I might give you this one then. Endodose deterioration, that's what I mentioned already, but it's a good try, good attempt. The answer is neuroleptic malignancy syndrome. Fantastic. Neuroleptic malignancy syndrome, somebody just put that into the chat as well, which is great to see. If you don't know much about that, I would advise that you go have a brief look at it. It is a medical emergency, so it's associated with the withdrawal of the medication, abrupt withdrawal of the medication. So do make sure you take a look at that. So far then, what we've done then, we've said, giving you a bit of an overview of what the CNS video contains. So there's quite a lot of stuff there with regards to the registration assessment framework, the key areas of focus I've highlighted, as well as some of the additional resources that you do get with that. So your revision posters, your case studies, etc. Then we went through the questions that you guys have sent through, and hopefully you found that quite useful. And in addition to that, we focused on a key area that you guys have either struggled with or you found useful, and I'm hoping that that's made things a little bit more clearer. So the next part then is to do with your questions whilst you are in the session. So whilst you are in the session, are there any further questions that you've got about the nervous system chapter? I've got a direct message from someone to say, what does NMS stand for? And I think that's because somebody else sent into the chat NMS. So NMS is neuroleptic malignancy syndrome, and that was in relation to what we were talking about a few moments earlier. We were talking about the Parkinson's disease medicines. If you withdraw them abruptly, they can cause neuroleptic malignancy syndrome. Now, over to yourself then. Any questions about the nervous system chapter that are bothering you, whether you've started or you haven't started? If you haven't started, don't be shy to ask any questions about how you could start. I'm more than happy to cover that as well. But I'll briefly pause for a few seconds and I'll see what your thoughts are on this. Do remember, it is the topic with the most amount of pages in the BNF. It can be quite daunting, but I'm actually quite impressed with the engagement that I've had from you guys throughout this session, because it does seem like you're picking up some of the key points of the knowledge. Okay. I'll just give it a few more seconds in case somebody's typing in something really long. and then we will summarize. Okay, questions are now coming through. Fantastic. So for someone that hasn't started this topic yet, how should we tackle it? So very good question. So with this then, as I did mention in the video at the early stages, is that it is a massive topic and it can be very daunting because you don't know where to start. I would say the best thing that you can do is have a look at the video, and that will obviously break down the topics. And each time you look at the video, the subtopics, press pause, and then just quickly go through the BNF on that area. So for example, if the first subtopic that you're going to look at in the BNF is dementia, then bring up the dementia part of the video, watch that in its entirety. Once you've done that, press pause and have a look at the BNF. And then you can link it in with any of the infographics or the revision posters so that you've got a well-rounded understanding of dementia. Now, understandably, some of you may not have seen the video, or you might not have, I guess, signed up to watch the video, which is fine. Everybody's got their own approach. So if you haven't, then the only other thing that I would advise is you sit down, you read the dementia section, for example. So do it a section at a time. That's the key thing. Do it a section at a time. Bring up the dementia video. So no, not the dementia video, the dementia part of the BNF. Have a read of that from cover to cover. Make some notes on this, because like I say, with the video, it brings out the key parts of the knowledge, but you might need to make notes based on what you're struggling with. So make them notes. And then once you've done that, you can say, well, dementia is now in its own little box. I'll put a lid on that, and now I can move on to the next part. And the next part, you'll see the BNF, they're doing it in a really nice way. They've broken it down into different subsections. So the next part would be substance misuse. The part after that would be, for example, pain. So just break it down into subtopics. That's what I would say. And then obviously when you go to practice exam questions, hopefully you'll be able to draw in on that knowledge. Because remember, with the exam, what the key thing is, they're trying to get you to link in different parts of the BNF as well. So don't try to work in silos. Initially, you do have to box off each topic one at a time. But in the end, your aim is to try and combine things together. So I know it's a bit of a long-winded answer to your question, but that is the answer to your question. Somebody asks, how could we access the video? It's available on our website. So I'll just post that into the chat, pharmacyfoundations.co.uk/courses. If you just go onto that link. We do obviously have sessions, either you can pick them as one-off sessions. So if you're only struggling with CNS, you don't have to purchase the whole course. You can just purchase that if needed. Or equally, if you want to, you can go ahead and get the whole course at a discounted rate. So that's fine as well. Let's see what else then. So how much additional revision do we need to do around the lecture? Okay, so I would say this answer to this question is based on what your baseline knowledge is about a topic, a given topic. So let's just say we're talking about CNS, for example. So if it's something that you've always struggled with, then chances are you're going to need a little bit more time on the video. So the video itself, I think, is about 2 hours and something long, maybe almost 3 hours long. And it might just mean that you're needing to pause the video a lot more than others. And that's fine. You can watch it as many times as you want. And it all depends on your baseline knowledge. I would say that if you're able to understand the video inside out, then in addition to this, it's just about looking and recapping on the notes, really. You don't need to do much more than that. Any directed reading or any directed study, we mention it within the video, we allude to it in the video, really. So any further reading would typically be things like looking at the infographics, or maybe quickly skimming through the NICE guidelines or skimming through the BNF, because everybody learns in a different way. So it might mean that you just need to skim through something just to kind of get your brain juices flowing, really. But with that video, to be fair, will cover most of what you need to know. And if it doesn't, then the infographics will cover the gaps. There's also the directed reading within there as well. So it just makes it a little bit easier, approaches it at a different angle. Obviously, reading the BNF can be quite boring, black and white, very, very easy to kind of lose track. So this just approaches it on a different angle. And also, who should we best use these how should we, I'm guessing it says, How should we best use these last few months to make the most of the time remaining? Now, the key thing with this, on our YouTube page, there's a video that I did on productivity, and I'll post it into our WhatsApp group again, hopefully later today. Have a look at that. Talks about productivity techniques. What I would say you need to do definitely 100% in the next few months, or for the next few months, is a revision timetable. Even if you're not a revision timetable kind of person, it needs to be there. And what you want to do is maybe from, well, we're looking at almost May now, aren't we? I would say middle of May. From middle of May, you don't want to be creating any new notes. So there's a difference between learning and revising. You want to learn whatever you need to learn from now until middle of May, but you want to try and create bite-sized notes if you can, or if you've got the infographics, use them as your bite-sized notes, so that from mid-May onwards, you're all, mainly revising and you're doing your mock exams and past papers and things like this. So that's what I would say, revision timetable, and try to get your learning out of the way by mid-May so that you can revise beyond that. So there's a difference between the two. I always get confused with NMS, serotonin syndrome, as the symptoms are similar. Can you help clarify? So the key thing with neuroleptic malignant syndrome and serotonin syndrome is that obviously with serotonin syndrome, there's way too much of serotonin. With neuroleptic malignant syndrome, it's the abrupt withdrawal of things like dopamine. What do you need to know for the exam is that both of them can cause seizures. Both of them are medical emergencies. That is all. Yeah. They're not going to ask you about the specifics of, is this a symptom of serotonin syndrome versus is this a symptom of neuroleptic malignant syndrome? You don't need to go into that much detail. That in itself goes into the realms of specialist care. So that's one of the key things is, we're not going to tell you to learn something in addition to what you need to know, because that's you wasting your time. Just know that they are both medical emergencies, and that should do it for you. Okay, perfect. That is fine. So I believe I've answered the questions there, mindful for time. So that kind of ticks us off for the CNS. Do make sure you do visit that video. The next topic will be skin, eyes, and ENT. I believe that video either is already active or will be soon. So do make sure you make use of that. And for those of you who are on social media, you will have seen that our mock exam is now also available to book. And that was available as of this morning, in fact, or midnight last night. There is a discounted offer available for the first week. So do make sure you make use of that by going onto our website. And last but not least, obviously, your continued support on social media is always appreciated. There's lots of information that we've got coming through on there. So do make sure you sign up to our social media pages. And if you haven't joined our WhatsApp support group, then the link is there on your screens, or the QR code, in fact, is there on your screens. Feel free to give that a scan. But like I say, thank you ever so much for taking your time out today to join the session. I hope you have enjoyed the drop-in, and I'm wishing you all the best luck or best of luck for the next few busy months of your schedule. If you do need anything, we are on, like I say, WhatsApp, so that link's there. But otherwise, feel free to get into touch. And yes, hope you do enjoy the remainder of your Sunday. Thank you.